like to extend my pleasure for the meeting and for the chairing committees, and I'm happy to present my colleagues and country. So because Egypt means a lot for us, this topic never been talked before. This day cannot be shown before. So hopefully we'll present this to the Heart Rhythm Society. As you know, it's the Hajj season. It's very unique circumstances for the unique people. And I'm just going to share with you a couple of insights, what we see, and I am happy to get some ideas just to bring them back home and hopefully develop our program. So there was no disclosure to this talk. I'd like to start with this. There is not only Saudi and during Hajj, it's multi-ethnicity, a lot of colors, a lot of diversity. There is no single language in the world that doesn't come from Mecca. So it's a different unique. And in one image, in one picture during Hajj, you'll see more than 10. I'll give you this data for the last 6-7 years. So in 2011, 2012, we have a lot of pilgrims at that time. There was a decline in the last 3-4 years, and that's because there is some national program and development and in Mecca region. For this safety, the government decided to decline the number of pilgrims, and in 2017 we were going back and picking back. 2030 represent the non-Saudi during the Hajj. So most of the people that come for each season, they are not Saudi. They are mainly they are outside of Saudi Arabia. So in show in hand, what is the most common arrhythmia you think that we face in Hajj? Is it SVT? Who thinks it's SVT? Complete heart block? All right. Atrial fibrillation? All right. Ventricular tachycardia? No. You're correct. Most of the people, they get atrial fibrillation. People are old and sick and do a lot of heavy duties and in a hot summer sometimes, and get pneumonia, get infection, and this is atrial fibrillation. We found it at around 41% of the, based on like in the 4 years consultation. It's around 845 consult, and this is only in the last 4 years. And when we say Hajj season, means 1st of Al-Hajj till the 15th of Al-Hajj. This is data represent only 15 days. Yes, the pilgrims sometimes they come way early and they stay way beyond the Hajj, but this is just the flutter and ventricular tachycardia and SVT. And SVT in those people sometimes will be resistant to medical therapy, or maybe because of the all exhaustion that they do during performance of Hajj. So what is the common ECG finding during heat stroke? The weather in Saudi in the summer can be very hot. And those people sometimes go to Arafah and stay in Arafah al-Fajr till al-Maghrib, and he's trying to avoid hydration. He doesn't want to drink water. He doesn't want to go to the washrooms because of the availability. There is a lot of concept. So those people, they get very dehydrated, and the heat stroke is very common around this time. So do you think there's a pattern or no pattern with during heat stroke? When I say heat stroke, that means the core temperature is 41 degrees. Heat exhaustion is around 38 to 41. But with the heat stroke, they have some mental change. So there is a definition for the heat stroke. So who said there may be nothing? What about non-specific ST changes? Right? Non-specific conduction delay? No? Complete heart block? Right? Let me answer this. So in the heat stroke, we find a lot of things. Sinus tachycardia is very common due to dehydration at that time. They have a lot. The sensitive one is non-specific ST changes that can happen in exhaustion or during the heat stroke. But during the heat stroke, the most specific one, they have non-specific conduction delay. So when I say specific, it's not sensitive. So when I see it in a patient who has a temperature of 31, that's our non-specific ST changes is a more sensitive. And when we have ST segment elevation, it's not localized. Cannot mask an anterior MI or inferior MI, cannot mask myocardial infarction. They have ST elevations like something like pericarditis, not localized to one area. This data of total cardiac procedures in Mecca during Hajj, this is 15 days data, that's it. From day 1 of Al-Hajj till the day of 15, And this is include intervention, BCI, cabbage, pacemaker, ablation devices. And you see that the numbers are going because we've learned and tried to get a system way to get into the patient and try to manage them early. So the numbers almost doubled between last year and this year, from 644 procedure to 1,314 procedure. And this is, again, this is only in 15 days, from day 1 till day 15. I want to show you this graph. This is number of devices in the last 7 years. We have 165 devices implanted during Hajj. Again, it's only 15 days now. We have dual pacemaker, the most common, single pacemaker, ICD single, dual ICD, and CRTD, and others. When I say others, it's a leadless pacemaker, and we start implanted this year, and mainly those for people in Saudi Arabia. The nationalities, it's multi-ethnicity. We see all things. So the most common, they are Saudi, because this is the most common unified nationality in Saudi. But in terms of others, the second one is the Indian, this is most implant. Then we have the Pakistan and Egypt. So this is the third, the Egypt will be the fourth country in terms of implantation device that's needed during Hajj. And the most people, 66, were male. So that's mean we have a lot of diversity. We have Afghanistan, British, Egyptian, Ethiopian, Indian, Iran, Libyan, Malaysian, Morocco. This is only for devices. If you're going to put the nationality for intervention, for BCI, you'll find a whole lot of nationalities. And those services all done for free. So what are our journey? I know that Ma'had again has a journey to improve their services. The same thing, we share the same thing, that we have a journey to improve ourselves. We started with devices in 2012, and this is number of devices in yellow part. In 2017, we have 39 implants during 15 days. In terms of ablation, we started growing up for the last 3-4 years. This year, we did 15 procedures for the last in the 15 days of Hajj. So total procedure in terms of EB, if we're concerned about EBs, we became mature maybe in the last 2 years only. Most of them we have pacemaker. This is the common share, the common implant. ICD 35, 13, SVT 10, WBW, that's sometimes first time diagnosed. And interesting, all those WBW they came with AF with WBW. They have no symptom, they presented with atrial fibrillation. And we started doing VT ablation during a Hajj for patient who has no ischemia driven. I'm going to show you the pathways for all those diseases. So what is the best time for you to do a case? Is it from 7 in the morning till 5 o'clock if you're in an AP center? Is it from 5 to 12 or from 12 to 7? 24 hours. So what do you do here? Most of the EB lab in the world is, our business has no emergency. The emergency that we have, complete heart block, put a temporary pacemaker. I have this patient who is Egyptian. He's a 65-year-old, came with non-ST segment elevation in mind. This is why you have to think about the mentality that we face. He came in the 8th of Al-Hajj, just 1 day from Arafah, with non-ST segment elevation myocardial infarction. Angiogram, he has a left main disease, almost 85–90%. He has lesion in the circ, lesion in the RCA, diabetic, and the plan for cardiac surgery. He declined the surgery. He said, I'm here to die. So our thinking when we talk to the people, always in medicine we talk about mortality benefit, morbidity benefit. There is a Arafah benefit. So the description, the discussion with the patients are totally, it's unwritten. We know you're never going to see it. This is why it's unique. So in terms of ablation, we do it 24 hours. I've done SVT at 3 o'clock in the morning because this patient needs to do an ablation and he wants to finish his thing. I've done a lady, she's a British. She came in with ICD. She had an ICD, but she came with 45 shocks from PVC-induced VF, We start the case at 2 o'clock in the morning. So to do this case, you need a team. This is not about physicians, it's always about team, and I'll show you what we have. This is how you have to think about Mecca. It's a small space, condensed people, no space. This is full of people that they are walking. Remember, like, imagine the heat stroke. Those people refuse to drink. He doesn't want to go to the washroom too frequent. So it's a very unique. By the way, this is not books. This is buses. They are lined up to go from a spot to a spot. So, and just to put you in the map, this is the hospital that we work in. It's King Abdullah Medical City. We have here Mina. We have to get a connection between here and there. Muzdalifah, Arafah, and when they finish, when they go to Al-Kaaba. Mecca is not like unified land. There we have a lot of mountains. You cannot go from one spot to a spot unless you go through a bridge, you go through the tunnel. There is not an easy way to get the patient around. So this, to go to this hospital, you need to think about staff. We have 3 cath labs. One of them is dedicated for EP. We have an on-call system for 24 hours for the EP system. For the referral, we have the hotline. We have a phone that you call consultant. If EP consultant will answer. If you call to the intervention will answer. We have the online. We see less fax referral. We have the online system that you get notified by people. How to get them? That's, I think, what is make this year different. We have the ER of the hospital open, but the patients were not going to come to the ER. We have to get them into the hospital. We have the Red Crescent ambulance. This year we activated the air ambulance. Patients who's in Arafah, had an MRI, has a complete heart block, get the management, air ambulance, pick him up, helicopter, and get him into the hospital. So the rush time is actually the day before any language in the world. They are not available in the hospital. 2 o'clock in the morning, you don't speak Kwantis or Japanese or whatever. You can find someone who speaks the language to help. In terms of beds, we have 34 CCU beds, telemetry 79 beds. Other services, CT, MRI is a 24 hours call. You do it, you came patients at 1 o'clock, you want to do MRI, 3 o'clock in the morning, you're done. As I mentioned, the customer are different, so you have to keep the hospital running. And the other thing that I found it useful is the networking. I try now, I know people from the Malaysia, I know people from EP doctor from Indonesia, from India, from Pakistan, because when I implant, I have to send them the report and let the people that did the procedure where the best center to follow up. I don't have a problem with Egypt because we have a lot of electrophysiologists. But when I have a patient from Tanzania, we have a lot of trouble. Sometimes people, they travel from country to a country to get their device checked. So this is all the learning process that we get. Where is the patient from and how he can get follow-up. And that can sometimes change our management plan. We came with the pathways to improve the other services. So complete heart block. Let's say patients in Arafah get a complete heart block. First you get the hydration, get the blood test, get the IV. If it's not a QRS, they will send him, fine. If it's a wide QRS, 2 p.m. on site, and we have to train people how to put the temporary pacemaker in those small peripheral, regional, seasonal hospital. And after that, we transfer. If the road is fine, Red Crescent, ambulance. Road is not fine, during Arafah, after Arafah, you have to go with the air ambulance. Once you get the arrival, echo right away. So we know about them. We're not surprised that the patient is coming. We know that the patient is coming. So there will be a team doing the echo once the patient is regional wall motion abnormalities, elevated cardiogram, then everyone will go for an angiogram. And if then if they decide there is no reversible cause, pacemaker done, 30 minutes, 2 hours, he's going back to where he came from. If he has a transient heart block, so we'll do 12 hours observation in-house. Sinus echo as a cardiac MRI is needed, as my colleague Dr. Hatibation mentioned about the MRI, what is the useful of the MRI. And VT ablation, we do it if the patient has recurrent VT and no sign of cause, there's no ischemia. At that time we do the VT for him. ICD really depends on the app, but now I'll consider a lot of things after Dr. Saad taught us today, and we will follow. Sometimes if you have VT, slow, hemodynamic stable, ejection fraction more than 40%, and he's coming for a country that there is no good follow-up, sometimes we just do VT ablation. If there is no induction during VT, we will be happy on that time. CRT, backway, EF, heart failure, lip nothing, that's standard. And we learned a lot of the cardiac MRI. We kind of know who's the patient, will say, okay, they'll give him 3 months, follow up and see what is the echo looks like. If it's improved, no need surgery. In Mecca, we didn't have the pleasure of that because this man is going, he's leaving the country. We try from the cardiac MRI to learn which one we think that he's not going to reverse. If you have a lot of scar, give him all the medication that the ejection fraction will not improve. So again, it depends on the country that he's going to follow. If he is going to a very poor country with no electrophysiology, we try to spur non-emergent, non-critical patients from devices like that. So this is not my job. To have this done, you need a team. So we have the team, we have the anesthesia, it's a big lab. My team depends on 2 consultants. We have 4 EP technicians, 12 hours call, cardiac anesthesia 24 hours, and we have 24 hours EP coverage. With this, I thank you.